Nicole, and I'm doing multiple system atrophy. It's also known as Shy-Drager syndrome. There's other names there, but I'm not going to go into them because they're not as common and hard to say. What is MSA? It's a sporadic neurodegenerative disorder characterized by Parkinsonian signs or cerebellar signs, autonomic signs, and pyramidal signs, which we just talked about today, are the motor, involved in motor function. The pathology of MSA is alpha syncline on the glial, and that's that image there, shows that. And the mean survival is 6 to 9 years. It's a pretty fast progressive disorder. And I just wanted to point out, the first symptoms of MSA are Parkinsonian, so a lot of times it's confused with Parkinson's disease. And here I talk about some other Parkinsonian disorders. MSA accounts for only 8% of those, so it's also very rare. Parkinson's disease, some quick differences. Alpha syncline clusters are on the neurons for Parkinson's disease versus the glial cells of the brain in MSA. With Parkinson's disease, they do respond to the dopamine replacement. That's the levodopa, which a lot of people have mentioned in their presentations last week. But MSA does not have this response at all. And they also have the added autonomic dysfunction, which is blood pressure, urinary incontinence, erectile dysfunction, all your automatic. So I'm going to talk about Gary. He is a 67-year-old male. This is pretty common this is more common in males, and he is, it's also common greater than 50. It's not common. I told you it was only 8% of Parkinsonian disorders, but that's where we're seeing the appearance of it. He is currently diagnosed with multiple system atrophy, but he was first seen in 2010 for his Parkinsonian symptoms: rigidity, postural tremors, frequent falls, and beginning signs of dysarthria. And he was prescribed levodopa, but we know he was not responsive to levodopa. He also didn't have any dyskinesia effects from it, which happens in about 50% of users. So that's good. Lucky. He needs some good news, right? He presented with dysarthria within the first year, which is shows how quickly progressive it is. It doesn't occur that quickly appear that quickly in Parkinson's. He also had some respiratory insufficiency. His wife noticed some noisy breathing during sleep, and he was diagnosed with sleep apnea. He also has urinary incontinence and erectile dysfunction. The physician diagnosed probable MSAP. The P just stands for Parkinsonian symptoms versus more cerebral symptoms being the more obvious presenting. So the physician referred him to a neurologist, and in May 2012 he had the definite diagnosis, which just means they could actually see the alpha syncline cells on the glial. He currently has mixed dysarthria, hypokinetic dysarthria, and this is a typo. It should be hypophonia. I've missed the P. I don't know what. It's all kinds of messed up that line. This is the reduced volume of speech. He also has monotonous speech, and he recently was found to have bilateral vocal fold paralysis occurring. The otolaryngologist scheduled a tracheostomy, but he hasn't had that done yet. His posture has been increasingly getting worse, and he does have some tremors. So he's currently in a wheelchair, and it's just, he can walk, but it's just too hard to walk any distance with these tremors and his postural issues. He has as I said, lateral incontinence and erectile dysfunction. He also has low blood pressure. This is just kind of for your reference. This is how symptoms of MSA present. The initial are on top and later occurring are on the bottom there. And this I just wanted to show you. He's kind of past the initial. He has a little more problems, but he's not quite into the later. And as you remember, his first symptoms appeared in 2010. So he's in the 3rd year of diagnosis and or of the initial symptoms. And so with a 6 to 9 year mean survival, he's almost halfway through that. So he's progressing pretty quickly and he has a lot of issues coming up. For assessment and treatment, I did sustained valve phonation, altering motion rate, that's the pitika if you're in speech sounds, and sentence recitation, that's just repeating a sentence I say. That was looking for valve phonation and running speech. His sustained valve phonation was 10 seconds, which is not good at all. Norms are 25 to 35. His altered motion rate was 3.5 syllables per second, which is not good either. Norms are up around 6. I also did spirometry, and his volumes were low. He had a lot of issues with that as well. So for strengthening his respiratory system, we worked on spirometry. I didn't focus a lot on articulation because it's gonna just continue to get worse. And especially now that he is gonna have a tracheostomy, it's just didn't seem important. Also, I did a videoscopy and it showed some aspiration during swallowing, so I taught him the chin tuck with head turn and supraglottal swallow. I did want to mention that there's no assessments or treatments specific to MSA. As far as SLPs go, a lot of the presenting speech deficiencies are really similar to Parkinson's disease, so that's kind of how you can think of it, I guess, but just know that it's different and there are other problems involved. So I focused a lot on augmentative communication. He's not gonna get better, so we just need to make him comfortable at the end of his life. And I chose this rather than any, the burp speech or anything with the tracheostomy, because he's gonna lose some of that ability as well. And I think just skipping right to augmentative communication and teaching one way of communicating would be better than throwing all these different techniques at him that he will only be able to use for a short amount of time. But things to remember when picking an augmentative communication device for Gary. Vision can be affected by this disorder as well, so you don't want a small screen. He also has tremors, so you don't want small buttons. It could get complicated. You could say inappropriate things by accident. He also does have language, and you want to keep that in mind because you don't want to dumb it down too much. That could be psychologically mean. There's also some that have, oh, okay, that's good.
So you just want to take 10 seconds and wrap it up?
Well, I was just going to focus on augmentative communication with them.
Okay, thank you.